All right, so it's great to be here. We really want this to be interactive. This is a small enough group, right, that we can be interactive, and I'm hoping that you all are willing to kind of put yourselves out there and talk about what we were presenting, and give us feedback and give us your reflections, because that's really going to make it richer and deeper for all of us. Because we can talk about health equity, which I'm going to talk about a lot. We can talk about all these things ad nauseum, but in order to really like embed them in our practice and our way of being, we really have to wrestle with some of the concepts and what they mean for how we work and how we interact with people in the healthcare setting in order to really make it real. So I'm really hoping that we can have that interactivity today. So to get that started, okay, I am now going to struggle with this. Let's see. There, to get started, I want to ask you all to think about a time. I want to put us in the place of being patients, right? Because we're all patients and we're also all involved in the healthcare system in different ways, right? But ultimately, all of us are patients. All of us are family members of patients. So we all interact with the healthcare system on the other side as well. So I want to think of a time you or someone you care about had a bad healthcare experience. Think about what happened. And maybe just take a moment to think, and then I'm going to ask you if anyone wants to share anything in terms of what happened and what could have been done to make the experience better. I'm testing you out on your interactivity early. Yeah, Celeste, did you have anything to say, or do you just, it's okay.
I can just give like a broad example.
Thank you.
My patient this morning,
okay,
has endometriosis and finally had surgery for it. And she, this morning, like after the surgery, was just reflecting on how she's had a number of providers in the past who ignored or didn't listen. And it was a delayed diagnosis, as many patients have with endo. And so I think it's just listening to patients and trying to get them answers, even though we may not know the answers.
Which is scary when we don't know, right? And it can be challenging for us to acknowledge when we don't know. Yeah. Have people had experiences as patients or as family member of patients where they haven't felt like they've been listened to?
I have one I can share.
Okay, 1 second. We have one person sharing. I'm sorry, I know you probably can't hear, but then I want to hear what you have to say. Thank you.
Oh, okay.
I'll let you know.
So going to the emergency room and not being allowed to have anything to eat or drink for the entire day, not being able to get her meds, even though as a physician, I pointed out, perhaps you might want to get her meds and don't listen to me, and clearly would not, she's not able to advocate for herself. So that happens frequently.
Yeah, I reflected on that a lot with my parents as well, that if I, as a physician, am not getting this care, then imagine how bad it is. Yeah, exactly. Yes, one second person on Zoom. Yes, Rachel. Yes, good point. Yeah, thank you. So that was reflecting on going to the emergency room with the parent and them not getting their meds or food or water for the whole day and not being listened to and asked about that. So Zoom participant, so appreciate you speaking up. What would you like to share?
Yeah, my experience, so my mother had actually presented to her primary care, and she was really upset, and she was convinced that she thought she had breast cancer. And the provider thought she was being hysterical. So they didn't do any further evaluation or workup. And then it was like 6 or 9 months later, she came back and she had advanced breast cancer. So I think the lesson there is, listen to your patients when they're worried and when they're concerned.
I'm so sorry that happened, and thank you for sharing that. And I would say that sometimes patients are going to be worried about something that doesn't end up being real, right? And we still need to listen to them and make them feel respected and cared for. And thank you for sharing that.
For sure.
Yeah, someone else?
I can share another one.
Sorry, one question, one moment, Zoom participant, and then we will get to you. Go ahead.
You did an ultrasound done, and they said the quickest we can get you in is a month and a half. And then in return, I also had a patient in clinic, and they needed actually stat imaging. And they called TGA, John Hospital here, and they said the quickest we could get you in is a week and a half. And that was for stats. So just, adding to even more stress because you can't get the necessary tests.
Yeah, timely care is really important. Yeah. Thank you. And on Zoom, what were you going to share?
Yes, this didn't exactly happen in the US, but my mom and I, we immigrated to Italy like a while back. And basically, because we're Dominican immigrants, they thought that my mom specifically, she was a sex worker. So she went to the hospital. Turns out that she had sepsis because of the surgeries that they did, but they treated it as a STI or like an infection, like sexually related infection. And basically, up until like she was almost dying, they didn't do any other exams other than vaginal exams because they thought she was a sex worker.
Why would you feel that she's a sex worker?
Right, right.
Yes.
Yeah, so could you all, okay, I'm gonna repeat that. So this, in Italy, she went to the emergency room with her mother, and they made assumptions about her being a sex worker, and therefore her illness was only viewed through that lens, and she only received vaginal exams and not a comprehensive workup that actually would lead to the diagnosis that she had, which sounds like it was sepsis. Again, I'm so sorry. There's so much trauma that we experience in the healthcare system, all of us, and I just, it's heavy. So thank you for sharing that, and I'm so sorry. I think we all probably, every story that's being told, I'm like, oh, I had that story, both professionally and personally, that is related to that. And I think we all probably are having that experience, right? It's coming up. So I just think it's really important to name that and remember that, because it's when we get in our busy days in clinic, it can be easy to kind of switch over to the other role and not see the person in front of us as a person who also has a family, who also has concerns, also has a lived experience. And it's not because we're bad people, it's because it's hard, right? It's hard to maintain that perspective. And so that's what we really want to kind of center today, is thinking about that. So let's shift. What about a good experience? Can someone share sometime, hopefully there's some out there, a good experience and what made it a good experience?
Is this like in a clinical setting?
Yeah, as a patient.
And I was obviously nervous and like kind of like shy. And so I went in there and the doctor was super nice and open. He had like croc charms on his feet with like Star Wars. And he was talking to me and telling me how his son went to my school. So he made it kind of personalized and it kind of helped me open up and not be so like scary.
That's lovely. Thank you. So first time at the OB, croc charms on the shoes, Star Wars, very like open and like and made you feel very comfortable. Is that accurate? Okay, thank you. Anyone on Zoom have something they want to share? Okay, anyone not on Zoom? Another good story to get us started? It's got to be more than one good story. Yes. Thank you for sharing that. There's so much in that story. Yeah. So third time going for a concern to a different hospital, and finally felt listened to, looked in the eye, not on the computer, took you seriously and recognized that you, and also had looked at your records and had gone back and seen that you'd been to other places and acknowledged that as a source of pain, right? Yeah. Okay, great. Thank you all. Hopefully you've all feel grounded in kind of what we're doing here, right? I think that was really, really powerful. So thank you. I actually haven't done this exercise before, and I'm going to do it again because I think that was really, really incredible. Okay, so now we're going to take a few moments, and hopefully we've set the bar for interactivity. I really appreciate all of you who stepped up. There's a worksheet that was either handed around or emailed to you or at your tables. Okay, great. And I just want you all to, now we're moving more into the, sexual and reproductive health space. I just want you to take a few moments and complete it. I just want to acknowledge this worksheet is gendered, and this is from 2016 from the Title 10 Training Center, so it's been around for a while, but I think it's otherwise really good, so that's why we use it. Oh, it's the one that has like 8 questions. Let's see. Do we have an example? Let's see. It's this. It's one that looks like this.
Do you have any more?
Did we order the extra? Yeah. Oh, there you go. Sorry. Okay, just take a few moments. Don't think about it. You don't have to share anything, but if there's anything you want to share afterwards, we will be inviting interactivity. Like most people are finishing up. Feel free to keep looking at it. But does anyone have anything they're comfortable sharing about any thoughts that came up while they were filling this out?
Were very tough.
Great.
In different ways.
In different ways. Yeah. Great. I think that's why it's an oldie but goodie. Do you anything particular you want to share?
Nothing, but it made you think, like, what is your natural sort of response versus, you know, where might this person actually be coming from? What's their motivation, you know?
Mhm.
Yeah.
Yeah.
I guess for me,
Yeah.
the things I thought in my head, but as a physician, I was not seeing them.
Yes. Right. And I think that's really what we're trying to surface here is we all have triggers, right? We're people, right? We have triggers, and some of those we can kind of consciously think through and recognize and kind of, you know, for me, for example, natural family planning, like, is something that when I did a family planning fellowship, I was taught to dismiss that as a approach to people's fertility regulation, right? And in fact, I've learned consciously how important it is that as a person-controlled form of making decisions about your body, understanding your body, and non-hormonal, all those things, how important it is that that's an option, and that actually I'm depriving people of their options if I can't counsel them about that. So that, yeah, I can consciously overcome, right? But there's other things that can be a little bit harder to recognize and to necessarily consciously overcome. So that's why we have to keep it from interfering with our interactions with our patients. And just like you said,
I think for me, reading this, and I work a lot with young people, and so for me, it actually is encouraging me to probe more. I
Mhm.
want to know more.
Okay.
So you're smoking and you can't afford birth control. For me, I want to learn more. I'm not, my inclination, I'll be honest, my inclination, what you can afford, but then I'm like, no, you're smoking for a reason.
Right.
So like, I think in the condom, I don't want to be a dad. I don't want to use condoms, that kind of thing. Like, to me, it's easy to judge. Then I'm like, but what are your values or what are your thoughts around those things?
Right.
And so I think for me, I want to know, I think I'm learning to want to know more.
Right. Curiosity is really important. Yeah. And also recognizing even if we can't know more, there's a lot there that we don't know. Right. And so it's not the top line. It's like recognizing there's depth.
Mm-hmm.
Great. Anyone from Zoom have anything they want to add? I'm sorry I didn't repeat all of that. I'm realizing now. Rachel, you have to probe me. What? You're putting, oh, you're so great. Thank you. That's so much better than me repeating it. Okay. Great. Okay, well, thank you. Hopefully you can carry with you some of this, like both the what makes a good healthcare encounter or a bad one for you at the beginning, and also then some of these things and what they made you think about as we go through this training. Wonderful. Well, thank you all for leading us off with so much interactivity. It's not working, Rachel. I'm sorry. Okay, so how am I advancing again? Now I can't remember. Right. This, okay, there, thank you. All right. Okay, so we're going to start with just talking about some core principles, which you all have already actually talked about a lot today. But we're going to just name some things that are really, I think, fundamental to quality healthcare delivery in general, but also in the sexual and reproductive health space specifically. So you have all probably heard of patient-centeredness, correct? I'm going to talk about person-centeredness and how that is really related to patient-centeredness, but going a little bit further, kind of along what Jill was saying. So patient-centered care, which hopefully you have all heard about, is something that actually is relatively new. When I was in training, it wasn't something we talked about. We were all about evidence-based medicine, right? And that was like the thing when I graduated from medical school in 2002. We were talking about evidence-based medicine. And actually this report, Crossing the Quality Chasm, that came out in 2001 from the Institute of Medicine, was really what put patient-centered care on the map. Because the reality is, most of the time, when you're talking about evidence-based medicine, when you're talking about guidelines, you're actually not talking about patients' needs, values, and preferences, right? You're talking about data and what we should be doing based on the evidence. And so there was, I think, a little bit of a recognition that in doing that, in prioritizing the data, which is really important, we're running the risk of not paying attention to people as people, patients as people. And so in this Crossing the Quality Chasm, Institute of Medicine named patient-centeredness as a core dimension of quality of care. So it's about safety, it's about efficacy, and it's about patient-centeredness, and it's about equity. That's another dimension, which we'll get to. And they defined it as care that is respectful of and responsive to individual patient needs, values, and preferences. And so it's one of the things that is really important is that this is an ethical idea. We should be honoring people as people when we're taking care of them. And it's also associated with improved outcomes. When we honor people as people, their healthcare is better, and therefore their health outcomes is better because they can engage, because there is trust, and because they are getting care that actually meets their needs as opposed to what the evidence says. So this is the definition of patient-centered care: respectful, like I said, to patients' needs, values, and preferences, coordinated, integrated, informative, physically comfortable, right? That's important, emotionally supportive, and inclusive of patients' social networks to the extent that they want it, obviously. So that's patient-centered care. We talk about person-centered care. You know, our program is the Person-Centered Reproductive Health Program. And the reason we do that is what Jill was saying, that we want to honor people as people and not just when they're in the front of us in the room, right? That's, you know, people come in and they become dehumanized often in the healthcare system, right? Which is not what we should be doing, obviously, right? And so we want to make sure that we're thinking about it, not just the moment that they're with us, but what's the life that they're going back to? What's the life that they bring with them? What's their lived experience? What's their lived experience with healthcare? And that's why we really name it as people. And it's really important to recognize that there's a lot of trauma and harm in the world, right? Of various different kinds, right? There's trauma in our personal relationship. There's trauma in interactions with correctional officers. There's trauma with schools. There's trauma with the healthcare system, right? And so people bring that with us into the healthcare system. So the trauma-informed care model is really about operating with what's called universal precautions for trauma, like recognizing that we do not know what people bring in with them, right? And so their personness, who they are as people can include a lived history of trauma. And we have to assume that to be the case and operate from that starting point and not operate from a place of assuming that people come in and are just like ready to hear everything that we have to say and what the evidence says without any with any reactivity or any sense of reaction that relates to who they are in the world and how they've been treated in the past. Okay, so one of the core dimensions of person-centeredness is communication. And that's really what we're going to be talking about today, is communication, right? There's obviously lots of things that relate to person-centeredness that include whether you get your ultrasound in a week and a half or 2 months. That really matters. We're not going to be able to fix that today, right? I wish we could. But we can talk, how we talk to patients makes a huge difference in terms of whether or not they feel like people, whether or not they feel like they're being heard and had their humanity recognized. So that is really what we're going to focus on today. And obviously, kind of from a very kind of pragmatic perspective, we need quality interpersonal communication to be able to know what people want, who they are, what their experiences are. And we also need quality and interpersonal communication to be able to talk to them and give them the information they need and the support they need to get the healthcare that they need. And so, like I said, we have data that patient-centered care in general affects outcomes, but we also specifically have data that interpersonal communication, patient-centered communication affects outcomes, including satisfaction with care. That's not surprising, right? But also use of medications that are prescribed, right? If you counsel people and find a medication that works for them through quality interpersonal communication, and they understand why they're taking the medication and all of the things, that they're more likely to be able to continue to take it. And actually, a study I did early in my career actually found this to be true for contraception specifically. The quality patient-centered communication, both based on audio recordings and based on patient report, was associated with patients finding a method that they were able to use over time. And I want to name that contraceptive continuation should not be the goal. Discontinuation is not a failure, right? Just want to name that because method switching is important. But the fact that people can find a method they can use over time is a good thing that we can support. Okay, so isn't all care patient-centered or person-centered? I already shared that this is kind of a relatively new concept. If you actually go on PubMed, the National Library of Medicine, the person-centered or patient-centered references basically start at 2001. It's kind of crazy. It just escalates from there. It really wasn't a thing before that. And just to name that this is not how our healthcare system is structured, right? It is not structured to be patient or person-centered. And that I always use this example. I'm a primary care doc. So hemoglobin A1C, which is a blood sugar measure that we do for blood sugar over the past 3 months, that is our metric we use for diabetes control. That is how our healthcare system related to diabetes is structured. I get every 3 months, how well am I doing in my patient's diabetes control, right? Is that a patient-centered metric? It is something we care about. We want patients to have good blood sugar control, but are they going to the emergency room because their blood sugar is too low? How are they having side effects from their medications, right? Are they able to afford their medications, right? That is not captured in this, but we fully structure our healthcare system around one metric. And so we really want to break that down and recognize that our default mechanism in the healthcare system is not to be person or patient-centered. And we have to be very intentional if we want to actually accomplish that. Okay, so do you have any examples of contraceptive patient-centered, person-centeredness in contraceptive care? I know we're behind time, so I'm just going to skip ahead, but I want you to think about that because we're going to come back to this. But here's some questions. So here, which one of these common clinical scenarios are person-centered? You can just read over those, and anyone who wants to yell out, let me know. And this is, again, thinking about this from a SRH contraception perspective. Can you all read it? Sorry, you're straining. I'll read them out. A clinic that's open 9 to 5, Monday to Friday. Is that person or patient-centered? No. Providing patient education at a high school reading level in English. Offering drop-in appointments. Yeah. Considering the possibility that patients have had negative interactions with healthcare providers in the past.
Yeah. Yes.
Pressuring patients to use specific contraceptive methods. Offering referral for social benefit programs in clinic. Right. So great. So there's a lot of things that we can be thinking about. These are kind of like high level examples, but in general, we want to be thinking about what are our patient education materials? What are our appointment structures? And then what's our communication like with patients? Okay. So that's person-centeredness. Okay, so how is this relevant to contraception care? Obviously, we want all care to be person and patient-centered. Contraception, what we're talking about today, reproductive health care in general, is personal, intimate, complicated, stigmatizing. People come in with lots of stuff around it, right? So it's particularly important in this context. We want people to be able to share with us and get what they need, their needs met. And if we're not offering them care that acknowledges their humanity, we're not going to be able to do that. And recognizing many people have had adverse experiences around sexuality and with sexual and reproductive health care. So even if we're the best person in the world to a patient, that doesn't mean they're necessarily going to respond to us the way we think they might, because they, again, are coming in with their whole personhood, right? And their lived experience. And we have to recognize that. Okay. Reproductive autonomy, that's the first guiding principle, person-centeredness. Reproductive autonomy is the human right that the individual has the power to decide about and control matters associated with contraceptive use, pregnancy, and childbearing. This seems obvious, but also it's often not what we acknowledge or actually adhere to in the reproductive health setting. So we'll get back to this a lot, but just want to name that this is a core principle that we need to be thinking about and recognizing, because I know you all care for young adults and young people, it does not have an age requirement, right? And we get very, we have a lot of reactions around youth, right? It can be challenging. Society has a lot of reactions around youth. So really naming that youth has reproductive autonomy is really important. Okay, and in the context of contraception care, we're going to come back to this. We often think about contraception as being something that facilitates reproductive autonomy, and it can, but it also can impinge on it. And Rachel's going to be talking a lot about that. So we have to recognize that how we provide contraception care can serve either purpose of impinging or facilitating reproductive autonomy. And so we need to be very intentional about our care and think about that as a core principle. And then the last one I'm going to talk about is health equity. So how do we define health equity? Obviously this is a painful thing right now, just naming that. In the federal government, but Healthy People, it's actually 2030 even still had this definition of health equity from the Department of Health and Human Services, which is the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, right? So not all health differences are health inequities, right? Because if they're not avoidable, for example, differences based on female versus male anatomy, breast cancer, testicular cancer, those kind of things, that's not an avoidable inequality. We also have to make efforts to address historical and contemporary injustices, and we have to eliminate health and healthcare disparities. Healthcare disparities being differences in how people are treated in the healthcare system specifically. So as we talk about this, we're going to come back to this, but we want to really think about what is the highest level of sexual and reproductive health. In this definition, it says the attainment of the highest level of health for all people. I want to name that we're going to keep coming back to this, but what I want you to hold on to is that what reproductive autonomy tells us is that the highest level of sexual and reproductive health is what the people themselves define it as. People get to define for themselves what goals they have, what they want, right? It is not about what we decide, right? And spoiler alert, I'm going to take apart the concept of unplanned and unintended pregnancy for you all in terms of whether or not that's self-defined versus it's something that we tell people that they should avoid. And then the other thing we have to think about is what historical and contemporary injustices affect reproductive autonomy and equity. And that I'm going to hand over to my colleague, Dr. Logan, to tell you about. Thank you.
I'll be back.
Not the end. Okay. So thanks so much, Christine, for that. Let's see. Okay, so let's talk a little bit about reproductive justice in particular. You know, we have the grounding and the foundation of health equity, person-centeredness, reproductive autonomy. All of those elements are necessary if we're going to actualize reproductive justice. Let's see.
Raise the screen up a little bit, so.
Oh, yeah, that's not needed at all. Let's see.
Sheesh.
Let me see.
I think just put a book on it, right?
Yeah,
Right.
exactly.
Okay.
Just
that
something, so
enough?
it's a little bit.
Okay, a little higher.
Is that need more? Okay. Do we have any?
That's better.
Yeah.
Higher, higher.
Okay, I have
Oh.
short stories. That should be.
Ooh, a little too high.
Yeah, okay. Anyone have anything in between? We could do these two.
I mean, anything, that's, if it needs to go back lower, any lift would be great.
Okay.
That's good.
It's all good. Okay.
That's good.
Okay.
Okay.
We're just trying to get the.
Rachel saves the day.
Thank you.
Uh-huh.
Okay. Oop. All right. So unfortunately, my poll is not working. I think people in the chat might have access to this, but we can just say what are the tenets of reproductive justice. Does anyone want to take a trial of naming all the tenets? Which ones would you select? Any brave soul out there? Okay, you said right to the abortion. Okay. Anyone else? Anyone willing to guess all of them?
All that.
Okay. Technically, the right to abortion is not a tenet of reproductive justice, but we're going to talk about that. Good. It was a good guess, though. So the tenets of reproductive justice, the primary ones, are that you have the human right to have a child, to not have a child, and to parent that child in a safe and sustainable community. So those were the original three. And then the National Asian Pacific American Women's Forum added that you have the right to bodily autonomy. Of course, within those tenets, you do have the right to abortion, but it's not specified. And that was in response and very intentional because the movement in the 70s, the women's movement, the feminist movement, really thought of women's rights as choice. And that was not responsive to the lived realities of so many different people. So many historians have talked about how these early feminist movements really centered the needs of middle-class white women. They wanted access to abortion. They didn't want to have these regulations and barriers to reducing the number of children that they wanted, but this wasn't the same level of priority for all populations. And so in 1994, a group of Black women, femmes, even transgender individuals gathered following an international conference that really reaffirmed this human rights-based framework. So you can go on the United Nations website and see the human rights list. Like, it's an extensive list of fundamental human rights, because they said this has to be more than choice. Like, yes, we want to be able to have bodily autonomy by deciding if and when we become pregnant, but we also want the right to have children. We deserve to have the children that we want to have. We deserve to have support in forming families when that might be difficult to have, for instance, biological children. And because of redlining, crime, police surveillance, all of these factors, a lack of high quality education, nutritious foods in their communities. When we have children, can we raise and parent those children in safe and sustainable communities? So it was more than choice when we're looking at populations who often historically lacked institutional forms of power. So it is absolutely inclusive of abortion, but it doesn't stop at abortion. But it's important to note when talking about reproductive justice that we have a clear understanding of what is like the opposition, right? Like what is reproductive oppression? Well, it's the control, and I highlight that because that's a key word that will keep coming up in our historical context. The control and exploitation of women, girls, and all individuals who can get pregnant through our bodies, sexuality, labor, fertility, and reproduction in the violation of our human rights. And human rights, the United States is one of these like higher wealth countries that has not formally accepted the human rights framework, right? And I mean, if you look at the news, you can see that that's the truth, right? But just because you breathe air, just because you were born, you deserve to have the right to bodily autonomy, to safe community, to education, food, to participate in civic engagement, to have political power and have your voice be heard, the right to religious freedom. All of those things exist just because you live. And so that has to be the foundation if we want to build upon it and ensure that people also have access to self-determine, as Dr. Dellendorf mentioned, their reproductive realities and shape those moving forward. And so there are multiple concepts that come up in this conversation. I mean, I remember in my training learning about reproductive justice, and I'm like, where has this been? Why aren't we talking about it enough? But the women's rights movement really focused on reproductive rights, as I mentioned before. And so this is a legal framework. It is meant to inform policy and advocacy around, as some scholars call it, like the negative right, meaning that the government doesn't have a right to interfere in your ability to access resources and services. So this framework, for example, uplifting like Roe v. Wade, was essentially a framework to ensure that the government doesn't create barriers to you accessing abortion. Well, that's quite different than the government helping you gain access to abortion. They're just saying, hey, we're not going to stand in your way. That's the floor, right? And then there were other policies that were created afterward that made it really hard for people to access this in an equitable manner. For example, the Hyde Amendment, which said no federal dollars will be spent on abortion. Well, who did that significantly impact? Does anyone know? Who would be most harmed from the federal government saying no federal dollars would be used for abortion care? Yes. It would be underserved communities. So now we don't all have equal rights to abortion. We now have differential experiences of that. So we see how policies and laws can shape our reproductive realities. And then reproductive justice is really interested in the positive aspect, ensuring that not only do we remove barriers, but we actually facilitate and help you achieve and self-determine the goals and outcomes that you want to see. In the well-being space, which we are in through the Power to Decide initiative, you know, we want people to have the sexual and reproductive lives and experiences that they want to have. So what do we need in order to make that happen, to facilitate that? And then in the reproductive health space, that's really around service delivery. So ensuring that people have access to screenings and contraception, access to abortion, and then ensuring the quality of care like person-centeredness and those aspects. And so they're not antagonistic to one another. Actually, they work in tandem. And so these three frameworks should coincide. Reproductive justice at the helm, a lens that we can use to ensure that when people have, that when we propose policies, that it's with this lens of ensuring that there's equity for all. or ensuring that we remove as many barriers as possible so that everyone can have access to these resources and services, and ensuring that everyone can have like a modicum of high quality reproductive health care and services. But this, again, is not possible. And our society is structured in such a way that, as Dr. Dellendorf mentioned, we have to be very intentional about embedding human rights into everything we do, lest we start missing people, excluding individuals. So if we were looking at reproductive health services, there might be key differences in people's experiences if they're able-bodied or not able-bodied, if they are a sexual and gender minority, if they are a person with a racialized ethnic identity, those kinds of things. And so removing those barriers and then embedding facilitators are really key. So part of this is ensuring that, for example, in Florida, as Dr. McCracken mentioned earlier about the bill that's going in right now, unfortunately, if it is passed, this would reduce access for young people to have sexual and reproductive services. I don't know if folks have been following along, but even one of the legislators recommended that, okay, we can see young patients, we can test them for sexually transmitted infections, but they would need parental consent to get treatment. How does that facilitate someone having the fullness of all the services that we can offer for them to maintain their sexual and reproductive health? It doesn't. That creates a barrier. So that is a key part. And I also want to mention, and like taking from the amazing work of Loretta Ross and other Black feminists, human rights are essential, but this is what your government owes to people it governs. And so some people are like, well, you know, the government can't take on all of that. They can't do all of that. They owe it to us. They govern us, so they owe it to us to ensure that we have safe housing, high quality education, nutritious foods, clean air and water, those kinds of things, because these aren't things that we can do for ourselves. If I could clean the air and the water and reduce the manatee deaths that we recently had, I absolutely would, right? But I don't have the power to do that. So I have to rely on my government to make that a possibility and a reality. And so the reproductive justice framework was exceptionally critical because not only was this not just about the choice movement, but these Black folks, these people of color who gathered together in 1994 understood that there's a continuity in our narrative as a country around oppression. And so taking from the timeline that was posted in the Healing Justice Lineages, this is a timeline of harm, of reproduction and criminalization in the Americas. But it's a abbreviated timeline. Like if you were to read this, I also have my copy of Killing the Black Body by historian Dr. Dorothy Roberts, really detailing the history of reproductive oppression across time. And it really begins as soon as the European settler colonists came over and started to shift Indigenous communities, their tribal norms and cultural practices. In order for them to build this new world that they thought they found, they needed labor. And so that's when enslaved Africans were brought over to work and to toil for free, no matter what the Florida education system says. And then because they wanted to expand the slave trade, they started instituting laws and policies. And one key law, I'm from Virginia, and this is the shame of Virginia, but one key law that they instituted was that anyone born of an enslaved African was indeed a slave. And that is quite different than the rules and norms in Britain, where your lineage is determined by your father's status. So like the peerage, you know, the dukes, the earls, all of that, that's determined by your father. But here in the colonies, in order to proliferate the slave trade, they switched it. And it was based on your mother's freedom status or emancipatory status at the time of your birth. So if your mother was enslaved, you too were born into slavery. And that created a system, which we now call chattel slavery, which is the foundations of capitalism in our country, to ensure that Black women, enslaved African women, remained pregnant or had high fecundity, like a lot of children, because this was helping to build the workforce. And as slavery proliferated in this country, there was also a need for more land. Like cotton takes up a lot of land, corn, rice, all the things that they were making at the time took up a lot of land. So they started to push out the indigenous people. Even the Tampa History Museum here, it does a really good job of detailing how that functioned and operated, showing the early indigenous cultures and then also their migration. And so that was the Indian Removal Act and the Trail of Tears, which the federal government at the time under Andrew Jackson removed indigenous people, dispossessed them of their lands, and shifted them outward during the winter with no food or supplies, and many women and children died along the way. And I bring that up because it's an example of dehumanizing people. And indigenous communities were seen as savages. And once they were out west, they also had to deal with the settlers that were out there. And this was a system that started to show a differential in who was in our country. So a certain group of people were enslaved, and another group of people could be dispossessed of their lands and culture. And we'll see this system of othering people and marginalizing them in order to strip them of their human rights and of their dignity. And another instance that I will mention here is the development of the birth control pill. Initially, when they wanted to do that testing before submitting their application to the Food and Drug Administration, they wanted to test a drug with little interference. And so at the time, Puerto Rico was indicated to be one of the most densely populated areas in the world. This was also post the height of the eugenics movement, but it had already been indicated that certain communities in the world needed to have their populations reduced. And so Puerto Rico was selected for that reason because it was indicative of a good place to have some type of public health intervention and reduce the population. And also the developer at the time didn't want media oversight. So Puerto Rico was selected because they assumed that those brown Caribbean people weren't going to fight them when they instituted their clinical trial. The media got wind of this and was wondering how come the mainland isn't having the same clinical testing. So people there were very interested in reducing the number of children that they had based on their own desires and needs, but didn't want to be coerced into anything. They wanted, of course, full information, so informed consent was limited. There wasn't full disclosure of side effects. And then when people complained of side effects, they were ignored. So this caused significant issues, including sterility and pain and other forms of suffering that were largely ignored. And they used these data in their application and it was approved, but the method or formulation that went to market was a much lower dose of the hormones than was tested in the individuals. And then from that time onward, we see ongoing threats to our sexual and reproductive health and policies at the federal level and at the state level. And if you follow and track these things over time, we see that we are given rights and given access, and then it's revoked and taken away, and then it's given back. And then, so it's been this tug of war throughout time around control. And in order to do health equity work, we really have to root our understanding of these concepts in the social and historical context. This means understanding that not everyone has had the same experience of sexual and reproductive health. And to this day, we still don't have the same opportunities. And what was slightly confusing at this time is as these innovations emerge, certain people did benefit, right? Like I'm talking about the negative aspects of reproduction, but there have been reproductive technologies that have advanced people's reproductive autonomy, have helped them have children or increased birth spacing and things like that. But this is also happening in tandem. So it is this complicated history, if you will. And in the 1900s, and this is work that's in tandem with some of Dr. Sonia Barrero's work. She specializes in sterilization and also really presents on the history. The 1900s in the United States, there was a robust eugenics movement, very robust. This was also around the time of fitness. So people were thought that if you were meant to have more children, you should almost have a certain level of fitness in order to be determined eligible almost to parent. And that often coincided with being white, middle class, Christian, you know, the whole structure of what America was supposed, I guess, to be in some capacities. And so there was a campaign, I think at the time around 26 states in the United States had formal compulsory sterilization campaigns. So sterilizing their own citizens. And this was a function of institutionalizing people for various things. You could be a sexual and gender minority individual. It could be institutionalized and then sterilized. They also, this says women, but there were men who were also sterilized. Again, if you were institutionalized, you were subject to having your reproductive rights revoked, essentially, and being almost experimented on. But that early campaign really focused on people with disabilities and sterilized many of them. And then institutionalization continues to be an issue with having your rights revoked. I didn't include the ICE detention center where the nurse whistleblower said that they were sterilizing and doing unconsented procedures on people in ICE detention centers, but that remains a very vulnerable position, is to be institutionalized in the United States. And then also just the targeted marketing of IUDs and long-acting reversible contraception in certain communities where we saw during the early opioid epidemic, otherwise known as the crack epidemic, there were financial incentives to people to reduce jail time if they got a LARC method inserted. And that is a clear form of reproductive coercion. But what about reproductive health care? That also, as one can imagine, has a complicated history as well. So even beginning with pregnancy and birth care practices where lay healers, which in the early Americas were often enslaved individuals, were the ones who helped people with their pregnancy, helped you restart your menstrual cycle, gave you herbs and tinctures to facilitate abortion or to have recovery after you give birth. There were midwives who also were, in some cases, enslaved individuals and called upon to catch babies. And then these were our early birth workers. Like they did everything pertaining almost to women's health, because at the time, there wasn't this physician structure in the United States where everyone had access to a physician. Many people did not have that access. And then for modern gynecology, many people now know about J. Marion Sims, who had enslaved Africans available to him and used them in experiments in order to further what we now know as modern gynecology, and also relied on the vast knowledge of lay healers and midwives to train him and have him train other people in gynecological practices. And so that information was extracted from Black bodies in Black communities. And then once the physician model became more legitimized in the United States, we saw a significant drop in the number of midwives and lay healers. And that remains a point of contention today, even trying to, Black Maternal Health Week was just recently, which I participated in, but even trying to say that doulas and midwives are welcome into the gynecological space is still a point of contention to this day, where there's a war on the territory around people's reproduction. And I kind of talked about this related to the early eugenics movement, where again, if someone had a sexual and gender minority identity, they were subject to all manner of harm through being institutionalized and having their genital and reproductive rights revoked, being subject to conversion therapy, and then just denied gender affirming care. And then reproductive technologies, while again, some people benefit greatly from them, those technologies, if not done correctly and implemented appropriately, help to widen gaps and inequities in sexual and reproductive health care. And so what is all of this? Well, it is a form of stratified reproduction. And it gets a little complicated because, again, we see over time that some people are afforded opportunities and advantages and other people are denied them. But those are often situational and can shift based on the needs of society, if you will. So, for example, when African people in this country were enslaved, it was good for them to have a large number of children and to have large families. But once enslaved Africans were emancipated, they now were vilified, and there were campaigns and efforts to reduce their family size and their reproduction. But a continuing thread is that there has been a system. So even as like Dr. Loretta Ross talks about, you know, from the early moments of our country, people were racialized to either be advantaged and privileged or to be disadvantaged. And that often crossed what we now call race. But before that moment, race did not really exist as a social construct. But there needed to be a system in order to ensure the continuation of power and advantages. And so the fertility of some people, and let's have an example. In this country, white women's fertility is the prime fertility that we are trying to have. Even with like great replacement theory and all those things, there's an effort to ensure that white women have more children because we want to, or not we, because I don't want this, right? But there's an effort to ensure that there remains a sizable pure white community in America. And there are these talks about the browning of the United States. And those are fear-based messages that have almost always existed in the United States. There's a concern that there are too many immigrants, there are too many brown people, too many people from different countries that don't get to represent what is a whiteness essentially. And even within those strata, there are differentiations. So let's take, for example, the Latinx community. Within that, in this country, people who are Mexican born, Puerto Rican or Dominican are looked at as less than someone from like a Colombia, a Bolivia, or for example, Spain. Even though they all may speak Spanish, there is a stratified way in which we view these individuals. Or as someone said, those S-hole countries, right? We don't want folks from there, and we don't want them to have large families and communities. And so this system is not just something like theoretical. It is now embedded in our laws and policies, our structures. It is in the way that, as we were talking about contraceptive counseling, someone may approach someone who may have a Black racial or ethnic identity and suggesting that they really use LARC. They don't want this person to get pregnant. They know for sure they're at risk of pregnancy. And they really just think that if those people limited the number of children that they had, you know, we wouldn't have poverty, we wouldn't have crime in our communities, or, you know, my taxpayer dollars wouldn't be wasted. And so there are social and formal policies in order to do that. And keep in mind that, again, if someone is institutionalized, that is a sure way that they may be vulnerable to having their reproductive rights and reproductive autonomy threatened. And so from the literature, we have seen that there are differential experiences in how people are treated during contraceptive care. So one study, I mean, we have data from probably 50 years back that have shown consistently that Black and Brown communities have reported experiencing race-based discrimination during care. But in the contraceptive context specifically, I start here in like data from that was published in 2005, where 67% of Black women reported experiencing race-based discrimination when receiving contraceptive services. Black people have reported that they are targeted for reproductive control more than others. And actually in the Higgins study, this was a study of people of diverse racial and ethnic identities, but many of them agreed that this was the lived reality for Black folks. And then Amico published a study around racialized youth report pressure to use LARC. And in some ways, there's some other data from providers where they describe it as almost being benevolent, right? Like they are looking out for their patients. They're trying to strongly encourage, if not urge, their patients, especially if they're young, especially if they're on like public insurance or live in certain communities, to use LARC methods, and they don't want them to take out the LARC. They want them to keep it. All of these messages that reaffirm that providers know better than individuals. And then other patients have also described pressure. And the LARC method or LARC methods are unique in that they are provider controlled methods by and large. There have been some studies that look into self-removal of IUDs, things like that. But by and large, you need a provider in order to have it inserted and to have it removed. So when you have someone who tells you they don't think you should have it removed, or you should try a little bit harder to manage the pain or the symptoms of a device that you cannot remove out of your body, that is a form of reproductive coercion. And there has been a lot of language that I think really constitutes almost a war on unintended pregnancy. Like in public health, at least, and probably also in medicine, you know, we are having an all-out fight on unintended pregnancy. It is like a primary threat in public health. And we have language that reaffirms this, like from ACOG, which talks about frontline recommendations. You know, that's almost like a war strategy, right? If you see person with pregnancy capability, the first thing you should do, you know, is recommend LARC to them. And then the family physicians picked this up, as well as the American Academy of Pediatrics, almost without question. And so IUDs and implants had existed before, but in our more modern society, this uptick of LARC first, education, counseling, and health promotion really hit the ground pretty hard. And even Dr. Deldorf could talk about being in conferences where it was almost like testimonials, right? If we're going to eradicate poverty, we're going to end these societal problems by having these little devices inserted inside of people. And then the way that we have been trained to educate and counsel people is also not really based in the best evidence, but it is based in convenience, and it reaffirms our belief that certain people need to have these methods. And so contraceptive effectiveness has been a key strategy in communicating about contraception, but that's not always the most important thing for patients, and that is contextualized. Like you may want a highly effective method, and also you don't want something in your body that you can't remove yourself, right? And so balancing these complex ideas and systems. And also this is in the context, at least in our time right now, where in Florida, there is no comprehensive sex ed. So when someone says they want highly effective contraception, do they even have a basic understanding of contraception in general? Do they know of their methods? But talking to people and learning about, okay, so you prefer to have something highly effective. Do you also prefer to have a period? Do you also prefer to have privacy with your method? Is it okay if it's an injection or something you have to return to the clinic to receive? Those kinds of things. And so after this large LARC first movement, there was then pushback and concerns that we were going a little too far in one direction. And so anecdotally, we would hear of providers talk about, you know, they didn't choose a LARC and I feel like I failed, or they wanted out. And I really am encouraging them to keep their long-acting reversible contraceptive method in. And then that whole conversation about waste and not having it in long enough to warrant the cost, and that being something that's put on individuals to solve when it's really a healthcare system issue. And so as we talked about earlier, like these are things we have to constantly grapple with and try to understand. And even after all of that, there are of course still people who are like, okay, but what about teen pregnancy? Like we gotta reduce those pregnancies and those young people. Like we know that it sets them up for failure. It's going to harm their life chances. Their life is going to be ruined if they have a kid before some magical age. Well, the data just doesn't align with that kind of thinking. It is convenient thinking. It has been thinking that we've had for a very long time, but the data just don't show that. Of note, I want to uplift that 75% of adolescent pregnancies occur in youth ages 18 to 19. That is often not what we hear. What are some things that y'all hear about adolescent pregnancy? Is there any like phrasing that we constantly talk about that just doesn't align with this data? Yes.
Babies having babies.
Babies having babies. We hear that so much. We hear it all the time. And I think in many people's minds, when we think of adolescent pregnancy, we are thinking of like a 13-year-old, and we don't want that to happen to them. And also they probably shouldn't be sexual and all of the things that really make it hard. But that's just not the exact reality. Also, there is this idea that you're going to ruin your life if you become pregnant before your frontal lobe is developed. Well, that also isn't the truth or the reality. And so there have been studies, including the sibling study, that saw that the effects on people's socioeconomic status were attenuated. So we thought there were huge gaps, like worlds between the person who had a pregnancy in teenage years versus a person who had it in adulthood. And that gap was significantly less, even in people who were siblings, right? And then there were some longitudinal studies in Baltimore that showed that for inner city, lower wealth youth from lower wealth communities, there were actually no significant differences in people who delayed pregnancy. And in some cases, there were improvements where having a child as an adolescent created opportunities for them to be motivated to go to school, to get a job, those kinds of things. Well, what's the long and short of this? The long and short is, again, in terms of differential experiences, we see the greatest differences in economic potential in really middle class youth, people who have great opportunity costs. But if you're born into poverty, having a kid early doesn't change your poverty status. You're going to probably still be poor, statistically speaking. And delaying pregnancy into adulthood doesn't really change that for you. But there are some differences in people who have more resources having a child. But one could also argue they likely would have more access to resources to care for that child as well. And so in a commentary written about this, it really just talks about the social inequality, especially poverty, is the context for adolescent birth and not a result of it, right? You're having children as a poor person, but you were poor before you had the child. So the poverty isn't caused by that, right? If you were already living in a low wealth environment in that regard. And that this idea that childbearing is an antisocial act and an important public health problem for us to solve, especially for urban African Americans, is a statement that is really hard to shift people on, because it's really embedded in our consciousness that, Black folks in the city are poor because it's almost like a pathology, right? Like it's just because, and if they could just pick themselves up by their bootstraps, their life would be different and our society would be better and all of these magical things would happen, but that's just not the reality. If we solve poverty, we're likely to see better outcomes. And so to drive this home a little bit more, like let's compare and contrast these two examples. So there's a 17-year-old lives in a 2-bedroom apartment with the mom, with a few younger siblings. Dad died of cancer. The mom became sick. So this person drops out of high school, decides to work to financially support their family. They have to walk and travel a long distance. They're in a food desert. There aren't many green spaces. They want contraception, but they can't get it because they don't have insurance and they can't afford it. They become pregnant. They want to continue pregnancy, but thinks they need an abortion because of their life circumstances. They would prefer to continue their pregnancy. They would prefer to continue their pregnancy, but they're unable to, or feel they're unable to, And now they're unable to access an abortion because of restrictions where she lives. Let's assume they live in Florida. Just wild, you know. However, this other example of a 16-year-old, let's compare and contrast this one, where they come from a family that is financially secure. They have a 6-month-old baby, and they spend each school day with a family member who can care for them while while the adolescent attends school. They live near parks and green spaces. The adolescent gets to get a part-time job to help with some minor expenses. They wanted postpartum sterilization, but their provider declined because they gave birth in a religiously affiliated hospital and they could not get birth control. They stopped breastfeeding because of all their scheduling issues. And then they changed their mind about sterilization, and then they decide to either get a diaphragm or do some fertility-based methods. So there are two people not very far apart in age that likely have very different experiences of navigating their sexual and reproductive health, not because of who they are, but because of the context of their lives. And I'm running out of time, so I will go a little bit more quickly. But in my early timeline, I talked about these legal systems and these policies, and even talking about the earlier opioid epidemic where people were criminalized for having children and all of these things. The legal system has definitely facilitated harm and instituted reproductive oppression, but they've also almost deputized healthcare providers to do the same, right? When we have instances of institutionalized compulsory sterilization, judges that may have ordered that or ordered LARC insertions aren't the ones doing the insertion procedures, right? It's the providers who are doing this. And now that abortion is essentially criminalized in the United States, we have data that shows that emergency room providers are the main ones who are calling the police on people if they were suspected of being pregnant and are no longer pregnant, right? So we're criminalizing people. And in this other case, people who were taking getting treatment for their drug use had the state take their children, even though they were trying to do what was right and were going to get some Naloxone. I don't know if that's the right. And so combining these concepts of reproductive autonomy, of health equity, of reproductive justice, and contraceptive care is really important for shifting and transforming care delivery so that everyone can reach the highest level of sexual and reproductive health. And so that means providers recognizing that there are social, economic, and historical contexts that really either promote and facilitate options and choices or constrain them, right? And then contraceptive care can either advance or restrict reproductive autonomy. So it's almost as if we're like in this crossroads and we have an opportunity in public health, in social service, and in clinical care to assist people in reaching reproductive autonomy or deterring them from reaching that. And so we're trying to move closer to assisting people in achieving and advancing reproductive autonomy. And then individual needs should be as people define them. And that's really hard. Again, as a public health person, we have these healthy people 2030 goals. We want the population to improve, but we cannot put population level issues on individual bodies. People still get to decide for themselves. And that may mean we need different strategies. We maybe need different goals if we aren't able to respect individuals' reproductive autonomy and create a healthier society. And so here are questions for folks in the room and online. You know, are providers responsible for achieving all of reproductive justice? What do y'all think? No, that's not reasonable. You know, we're talking about structural and systemic issues. One system in our society cannot upend all of this harm or facilitate all the well-being. It's one facet of the strategy, but it's not the end all be all. And can contraceptive care providers support and facilitate reproductive justice? Yes. Okay. And can they impede reproductive justice? Yeah, they can. And so we don't have time to go too in depth, but some examples are just considering the patient's full context. And I know that can be hard. We have other systems and interventions now that assess people for homelessness or being unhoused, that assess people for food security, all of those things. And your clinic, your center may not be able to do all of that, but you could maybe just acknowledge the full context of someone's life. Like, you came to the clinic today, and I know this isn't the only thing you have going on in your life. You may want to learn about contraception, but that isn't the only concern that you have in your life. You may have concerns about other things, and maybe I can help you with those. Maybe I can refer you out, or maybe I just can't address those, and that's okay too. I have to be all right with that. And considering contraceptive care delivery as part of people's sexual and reproductive health care. So I know this is the Reproductive Well-Being Learning Collaborative, but we have to bring sex back into sexual and reproductive health, even asking people about pleasure, even adolescents. If they have sex, they deserve to have pleasure too, right? People deserve to enjoy their bodies, and understanding and acknowledging that is really important. And then, as we'll talk about soon in shared decision-making, we're going to acknowledge that these individuals are the true experts of their lives. They know their bodies, they know their patterns, they know their access to resources and services or the constraints around those things. And so they are the best people to talk about when it comes to making these decisions and choices. And again, in order to realize human rights, we have to consider these structural inequities and differences. And here I just include a couple of books. If people want to read more about reproductive justice, I definitely recommend it. And we'll also include this later on in the slides. Okay, so for our quick discussion, we'll take like maybe 5 minutes here. Is that okay? Okay. We're just, if you can find one other person or 2 other people in your row, just quickly discuss, like, what about these concepts are new to you, if anything? And then how do you see these principles or concepts showing up in your clinic or your place of work? And are there places that you don't see them? So I'll give us about 5 minutes to just discuss if anything was new to you, anything that you're curious about, and then what does this possibly mean for you in the context of your professional work?
All right. So that was a whirlwind tour of reproductive justice, reproductive autonomy, person-centeredness, health equity, and the social and historical context in which we are providing contraceptive care, right? So what we're going to do now is talk a little bit about more of the kind of nuts and bolts of what does this mean when we're providing care, right? How do we incorporate and think about this? And what are some of the things we should be thinking about? Because it's hard. Rachel and I were just talking, like, our healthcare system is a hard one to receive care in, but it's also a hard one to be a provider and, in whatever capacity, interact with patients in. We are often stressed. We don't have enough time. There's not enough resources. We can't get ultrasounds. I'm going to keep coming back to that. And so it's challenging to hold on to some of our principles when we are actually indoctrinated within a system which dehumanizes patients and dehumanizes us, and also have time pressures and other pressures. So it's really important to be able to think through what this means and how we can actually actualize these concepts and principles. So I just want to say this is going to be 25 minutes in theory. We'll see how I do. So this is the very kind of brass tacks. The idea is that we're going to, one of our virtual sessions, we'll be doing more in detail about contraceptive counseling. So just hopefully those of you who are here and interested in that, we can see you again virtually. Okay, so I also want to say that not all of you, I think, correct me if I'm wrong, not all of you necessarily are the ones providing contraceptive counseling, right? And that's still really important that we talk about this with the whole team. And my second part of this talk is about team-based communication. So we're going to talk about kind of all the different ways that communication from different people throughout the clinic experience impacts patient experience. But I think it's really important that everybody, from the front desk to the biller to the person stocking the method, methods, everything is on the same page about what our interactions with patients about their contraceptive method choice should be in the context of what we're talking about. So that's why we think it's really important that everyone hears this kind of framing that we're going to give that draws on a lot of the context and principles that we already provided. Okay, so this is not a poll now because we didn't quite work it out, but that's okay because you all are such an amazing interactive group. We don't need to do it on polls. So I want you all to ask yourselves, what do you think is the best approach to contraceptive decision making? So contraceptive counseling, it should say. So is it to encourage people to choose the most highly effective method, give them information about all methods and let them decide for themselves, give them whichever method they say they want? None of these, I don't know, isn't that what you're supposed to tell me? So who thinks it's encourage people to choose the most highly effective methods? Who thinks it's give them information on all methods and let them decide for themselves? Okay. Give them whatever method they say they want. And none of these, and I don't know. Okay, so we have, that is often the response I get, and we'll talk about that. I'll problematize that a little bit. Not that it's wrong, but it's just, it's more nuanced. Okay. So Rachel already referenced the war on unintended pregnancy and kind of this first line language, right, that has come out around a LARC, IUDs and implants. And directive counseling is this idea that we should be providing counseling that is designed to promote the use of specific methods, which is rooted in our healthcare system, public health system, and healthcare providers' preferences or assumptions about what people should want or do want. And so that's encourage people to choose the most highly effective method that none of you chose. So this is, like I said, I did a family planning fellowship in 2006 to 2008, right around the time that Mirena was taking off and that Implanon was approved. And this was like the thing. We were all in. These were going to save the world, as Rachel said, like standing ovations at conferences around people reporting increased uptake of LARCs. And so this is just some examples of some of the initiatives that were out there at the time. This is from South Carolina, keep calm and get a LARC, right? So World War II slogan, people talk about war. Again, it's all about war, right? That this was going to be like, this is how we were going to talk to people about this, how they should choose the method. The LARC, has anyone heard about the LARC first approach? I mean, this is the first line, but the LARC first approach was actually initially came out of a choice project, ironically named, in St. Louis, which took a behavioral economics approach to counseling, which is basically mention methods early, often, and enthusiastically as a behavioral nudge to encourage people to use these methods. And in that study, they found 75% of people use these methods. And then they were like, look, we can save the world with counseling and encouraging people to use these particular methods. Also, motivational interviewing was used to promote use of these methods. Motivational interviewing, as I think probably many of you know, is an approach that was started in the context of substance use disorders, right? To help people identify their own motivations to overcome their substance use disorders in the ways that it was interfering with their own goals, right? So in the context of contraceptive counseling, it was like, how can we get people to overcome their ambivalence, right? That's the motivational interviewing talk. Overcome their ambivalence to use of these methods with the idea that not using an IUD was similar to substance use disorders, right? I'll let you problematize that in your head. I don't think there's a lot of complexity there that those two things are not the same. Okay, so I want to just break this down though. Is this patient-centered? I think you know that I probably think it's not based on how I'm talking about it, but I think it's really important to break it down why in this context it's not person-centered and how we can think about this. And one of the reasons that that's really important is because we actually do directive counseling a lot in healthcare, right? We often have preferences and think we suggest things to patients about what we think would be the best option for them. And that is not inherently unperson-centered to have a preference because we want to promote health, right? So directive counseling is actually appropriate when we have clear evidence, right, that something is going to produce a better health outcome. Substance use disorder, right? We would like patients to not smoke, to not use opiates, right? That is something that we think is better for them and for their health, right? Diabetes control, that's also important. A1C, like I said, that's important. Hypertension control, those are all important, right? We can do this in a patient-centered way, right? We can engage with people's needs, values, and preferences, right? in the context of their lives while having an agenda. That's what it's called, right? And motivational interviewing was actually created for that purpose, was to how can we do person-centered counseling when we have an agenda? I've had people tell me that, oh, I never have an agenda. I don't believe them. There are times when we as providers have an agenda, right? And we can sometimes subsume that agenda and like consciously overcome it. But there are times when we know that something is a better, a better health outcome. We would like someone with early stage breast cancer to get treatment. We would like people to take the tetanus vaccine. Like there's all sorts of things, right? So that's when we use directed counseling. In contrast, decision support is appropriate when there's something called a preference-sensitive decision. And a preference-sensitive decision is when we truly do not have an agenda, right? When we truly do not think there is one option that's better than another, right? And so to use breast cancer again as example, we want people to get treated, right? Because we think that will prevent progression, metastasis, and bad outcomes. But there are multiple different options for what people can do that have different degrees of different kinds of side effects, different treatment courses, etc. Right? And so we support people to consider between those options once we have encouraged them to have some treatment, right? Early prostate cancer treatment is another example. If any of you have had people in your lives who've had it, early prostate cancer, we often monitor. We offer people the option to monitor over time, kind of watchful waiting. But we also offer them treatment because for some people that's too stressful and they can't handle it and that doesn't work for them. So that's decision support is when we support people to consider the risks, benefits, and trade-offs for different options in the context of their lives and their values. So that leads us to the question, is contraceptive choice a preference-sensitive decision? So who thinks it is a preference-sensitive decision? Who thinks it is not a preference-sensitive decision? Who still doesn't understand what I mean by preference-sensitive decision? Great. Okay, I'm glad I asked that question. So, for example, I was going to use a primary care example, but that's not a great one, right? So if you have somebody who is diagnosed with, let's say, trick, right? There's different antibiotic options you can use, right? The CDC just does tell us, or at least used to tell us, who knows if they do anymore, if that website's up. But you would tell us what we would prefer. But if someone wants something else, right? One of the other alternative options, right? For whatever reason, because I can't think of the trick options right now. I'm sorry, it's not on top of mind. But there are different like treatment courses. It can take longer or shorter, right? So we can offer those different ones to people. We don't care which one they use, right? They're all effective, right? That is a preference-sensitive decision. What is not a preference-sensitive decision is we would recommend that they be treated for trick, right? That is something that we want people to be treated for. Is it easier if I put it in SRH context? So is that a little bit clearer about what I mean about a preference-sensitive decision? It's whether you have an agenda or not, whether you're trying to convince patients. Like I will give you an example. I know this is probably, again, I'm in Florida. COVID vaccines. I don't try to talk my patients into COVID vaccines anymore, right? I did at the beginning. Absolutely. I thought it was really important. I thought I had an agenda at the beginning, right? And now I think it's kind of, it's up to them. If they want it, that's fine. If they don't want it, it's fine. So it's shifted for me from being, I have an agenda versus I don't have an agenda. Is that a little bit clearer now? Yeah. Okay. So yes, so is contraceptive choice in this, now that I've clarified, is it a preference sensitive decision? Who would say yes? Okay, who would say no? Okay, great. So can you tell me why, who said yes? Why would you tell me why you would say yes? Someone. Yeah.
I said yes, because I think that the person should be able to select the contraceptive that they want to use. And it doesn't matter to me which one they choose. I just want them to choose the one that they're gonna use.
Right. If they want to avoid pregnancy. Yeah. Right. Yeah. And you said no, so I'll have to put you on the spot.
It's like, why are you changing your mind all of a sudden? They get a little like, they want you to get a contraceptive, even though like they're giving you all these options, they want you to choose one of them, and when you don't, they get a little pensive. They're like, why are you not choosing one now?
Thank you for sharing that. So you're not saying that you necessarily think it shouldn't be a preference sensitive decision. You're saying that providers don't treat it as a preference sensitive decision. Thank you for that, and that is true. Okay, so I am going to make the case that it should be a preference-sensitive decision, but I also agree with you that providers don't treat it this way, which is one of the reasons that I I'm willing to fly to Florida for a day and talk about this, because I think it's so important that we reframe this as not a war on unintended pregnancy, but a preference-sensitive decision. Okay, but it's a little bit of a complicated story, right? So I'm going to again walk you through this because I think it's really important, because there's such embedded things, just like the teen pregnancy thing. There's such embedded thing that our job is to prevent people from getting pregnant, and we have to do this. We have to give them LARC because it's the best method for preventing pregnancy. It's very hardwired and hard to overcome. So that's why I try to really give people kind of scaffolding for why we should think about this a little bit differently. So if you think about the question of, is contraceptive choice a preference-sensitive decision, it's kind of like considering, like I said earlier, about kind of substance use disorder versus an IUD. Is using condoms as opposed to an IUD or implant the same as choosing to smoke versus not smoke, right? Like, I have an agenda for people to not smoke, right? And do I also, because I want to prevent cardiovascular disease, I want to prevent lung cancer, right? All those kind of things. I have an agenda, and I prefer they not smoke, and it costs a lot of money, as was referenced earlier. I'd like them to save the money and not spend it on cigarettes, right? Do I have that same kind of agenda to prevent the adverse outcomes from smoking? Do I have the same agenda to prevent the increased risk of pregnancy? Because there is an increased risk of pregnancy with condoms compared to IUDs and implants. Do I have that same agenda? So, or is it more similar to early breast cancer treatment, like I said before, where I'm giving them these options, trade-offs? One of the benefits is increased risk of pregnancy, or decreased risk of pregnancy with IUDs and implants, and then there might be other considerations. So which one is that? So the case I make is clearly that it's a preference-sensitive decision, and I'm going to walk through that, right? So we know that individuals have strong and varied preferences for contraceptive features, right? Their methods vary in a lot of different ways. And if I was giving a longer training, we would go through all of those things, right? But just, you all know that there are over 10 methods, and they vary in efficacy, but they also vary in how you take them, and bleeding patterns, side effects, all those kind of things, right? So just to give you an example, nobody can see the slide. I'm aware of that now. But this is a table which shows, it was a survey that was done out of UCSF that asked people at family planning contraceptive clinics what their preferences were for different contraceptive methods, and basically asked what was extremely important, what's somewhat important, not at all important. And basically what it shows is that the method being very effective was the most important thing, but fewer no side effects, affordable, easy to get, easy to use. Whether or not you have control over whether to use it was extremely important to 70% of people. Not used at the time of sex was extremely important to 65% of people. So there's a lot of use is undetectable, does not change menstrual period. All those things are in there. People have strong feelings about this that they factor into their use of a contraceptive method, okay? So that's important because that means that people have preferences, right? Which is one of the things that we care about for a preference-sensitive decision. So this relates to different assessments of different outcomes, right? Like, some people love the idea that some methods will give them no period, amenorrhea, right? Some people love that. Some people hate it, right? That's a preference-sensitive thing, right? It's not right or wrong, right? Importantly, it also relates to different assessments of how important it is to prevent pregnancy, right? So people will have different feelings about how important it is. And that is why they will put different weight on the amount, on how important it is to use a very effective method, right? So 9% of people here said very effective was only somewhat important. People have different preferences about that. So that means that leads us into a narrative of it being a preference-sensitive decision. But the argument that is out there in the world is that an unintended pregnancy, and I put that in quotes, I'm going to break this down, is a universally bad outcome, right? And so our job should be, in this narrative, to prevent it at all costs. Just like we want to prevent stroke and breast and lung cancer, right? We also want to prevent an unintended pregnancy, because unintended pregnancies ruin people's lives. That's the narrative, right? And so similar to how we want to prevent stroke and lung cancer, we want to prevent unintended pregnancy. And that is what leads us to this model of directive counseling towards IUDs and implants. Because similar to how we should stop people from smoking, we should stop people from getting pregnant when they're not trying to, and therefore this method is better than any other method. That's the narrative. And if that is true, then we would have an agenda, right, of promoting these methods. And that was the underpinnings of the directive counseling model. So And then I'm going to ask you, is an unintended pregnancy always a bad thing? I know you already figured out what I think, but yes.
See, what's your definition of an unintended pregnancy? Because I guess for me, this is how, I mean, of course, sex and it's not always about the pregnancy for people, you know, it's
Most
for
often,
pleasure.
yeah.
But I feel like if you're also having sex, there's a high likelihood that you can get pregnant if you're not using any form of barrier, or you're not doing natural family
Yeah.
planning.
85% in 1 year. Uh-huh.
So I guess it's like, is it really unintended?
Great question. All right, let's hold on to that question, right? So yeah, there's a whole bunch of issues with the unintended pregnancy framework that we're writing a book about, as I said earlier. But one of them is measurement, right? Like, what does it even mean to have an unintended pregnancy, right? But so how it's generally conceptualized, you have a stated intention to get pregnant, right? And so therefore, if you have a stated intention to get pregnant, you are not probably coming into a reproductive health clinic and getting contraception, right? So based on that, if that is why they're saying you don't have a stated intention. So anyone who comes in for contraception does not have a stated intention. So therefore, the best method is an IUD or implant, because it's going to prevent you who do not have a stated intention to get pregnant from getting pregnant. What you're getting at is what I'm going to go in a second. So is an unintended pregnancy without a stated intention to get pregnant always a bad thing? Have you learned in your public health and other contexts that it is always a bad thing? That our mission should be to stomp out unintended pregnancy, right? Yep, exactly. And teen pregnancy, right? But that's a related issue, very much. Okay, so I agree with you that it's not. So let's talk about that. And I'm gonna, again, I think we all intuitively know that people have had happy accidents. Maybe you've had a happy accident, right? Whatever it might be, right? We know that, but then we get into our professional brains and we're like, but I've been told it's a bad thing, right? So I'm again going to walk you through the actual conceptual framing for why it's not always a bad thing. So intentions and plans are how we frame reproduction in the United States. And globally, they actually use this term, but they don't actually mean it. It's funny. They don't actually care about planning, but they just use it to kind of as a reference to undesired, fertility they don't want people to have. But in the United States, it's very much about we need to make people have a plan and they need to then execute it. And any reproduction that doesn't follow in that kind of, plan execution framework is undesirable reproduction. So, but what we know is that people have complex feelings about pregnancy, right? They have other considerations, and the ways this is framed in the social science literature is they have desires and feelings about pregnancy too. We're all not rational actors all the time, particularly when it comes to sex and reproduction, right? And family formation. The reality is this kind of put people, it has to be plan A and then execute B is a model of thinking that doesn't necessarily apply to our personal lives, to our sexual lives, to our family lives, right? And feelings like your emotional orientations around pregnancy, for example, are also relevant. And importantly, these do not always align because the model of unintended pregnancy assumes implicitly that if you are not planning to get pregnant, you would be devastated emotionally if you did, right? But that is actually been found not to be true. And so we have this model that is all about rational acting, and it doesn't actually take into account people in their lives, their humanity. It's not person-centered to assume that because it's actually fitting people into a framework that doesn't apply to everybody. It does apply to some people, right? It probably applies to many people in the room. It applied to me. I'm a planner and I was a planner in my reproductive life too. But that isn't what matters. It's not about me. It's about acknowledging everybody as people and the range of considerations that they have. So all of these things are different concepts. People may find all or some of these meaningful. Sometimes planned pregnancies, people are, complicated about once they happen, right? That's the other side of it, right? And they can appear inconsistent with each other. So there's some research that has documented this that I just pulled some quotes because I think it's helpful to see this actually kind of said by people. So this was a qualitative study performed by our colleague Jenny Higgins in Wisconsin, where she did this in 2015. And still there was not a lot of pushback against this directed counseling narrative and that IUDs were going to save the world. And so she actually did a study to say, okay, not everyone's using IUDs. It's not the 75% that was found in the Choice Project isn't actually what we're seeing. So why are people who are not using IUDs not using IUDs? To like take it away from like, how can we get them to use IUDs versus can we talk to them about why they're making their choices and actually like try to understand these people. And so one of her participants said, I guess one of the reasons I haven't gotten an IUD yet is I don't know, having one kid already and being in a long-term committed relationship, it takes the element of surprise out of when we would have our kid, next kid, which I kind of want. I'm in that weird position. I just don't want to put too much thought and planning into when I have my next kid. Right. So the unintended pregnancy framework here would say if she were to get pregnant, it would be a failure. She would go into that 50% statistic that we always talk about. Right. But for her, it would not be a failure. And then we also think a lot about ambivalence. This was a study done, I think most of these quotes, from Anu Gomez, who's at Berkeley. And there's also a quote here from Texas. So people have complicated feelings about pregnancy too, right? And they might not totally align with a planning framework. So for example, this one person said, it's like, it might not be the right time for me when I thought it was not the right time for me, but if I got pregnant, it's just how things go. It's like, well, everything happens for a reason, right? So again, our unintended pregnancy framework, and what I heard a lot, not anymore, but in our professional conferences and various situations was, this person, we need to talk them into planning. They need to put their money down. This is a problem that they don't have a clear intention, right? As opposed to meeting them where they're at and being like, okay, well, how can I meet your needs? So someone said, I'm not something I would really want, but if I found out I was pregnant, I would still be happy about it, right? That does not fit into the rational actor model. And that does not mean the patient is wrong. The person is wrong. It means our rational actor model is wrong, right? Because we're not meeting people where they're at. So, but isn't unintended pregnancy associated with bad outcomes, right? That is like the motivation behind people saying we need to get people to put their money down, right? And shouldn't we particularly get teens to plan for their own good, right? So that makes us ask, is an unintended pregnancy a universally negative health outcome? Have you all heard that it is, that it's associated with bad things? Yep, health outcomes, social outcomes, all those things, right? So that we are saving the world from unintended pregnancy and saving our patients. We are motivated because we are benevolence, right? That's part of it. Well, I can't go into this in depth because I'm already going way over my time, but the long and the short of it is there isn't data to support that, right? The data that exists shows very weak associations with outcomes, including like late entry to prenatal care, right? Which actually doesn't impact anything, right? We also, late entry to prenatal care is not the end of the world, right? And the studies and this is incredibly surprising that it doesn't show anything because the studies are actually really poorly designed as well. And so there's a lot of what's called confounding factors, which are things that are associated with adverse outcomes in pregnancy are also associated with unplanned pregnancy. And so there's a lot of like potential that we could see a big effect that actually isn't about the pregnancy itself. Similar to what we were talking about with teens having, poor teens having becoming poor, not because of the pregnancy, but because of their economic context, right? It's similar. There's a similar effect with unplanned pregnancy. So we would expect to actually see a pretty big effect, and we see a very small effect of these things on pregnancy outcomes. So what this tells us is that there's not a strong health or social reason to advocate against unintended pregnancy. And what this means to me is that not all unintended pregnancies are created equal. So I am not saying some people don't want to plan. Like I said, some people do. And some people need to plan because they would get kicked out of their house, right? Because if they were to get pregnant, right? And that's an important outcome for them to avoid, right? Some people have medical conditions that would be problematic if they were to get pregnant. And that makes them the decision. They get to decide if because of that medical condition, they want to avoid pregnancy, but maybe they're motivated to, right? So many people want to plan, but some people don't want to. And the universal framing of unintended pregnancy as a bad outcome it's lumping together apples and oranges. It's lumping together the unintended pregnancies that people really want to avoid with the unintended pregnancies that may be happy accidents and everything in between, right? So that is why the unintended pregnancy framework is not person-centered, because it's not acknowledging people in all their complexity. So bringing that, oh, sorry, I forgot I added these slides. So, but don't some patients need to prevent pregnancy? Like I said before, right? Like there's some people with medical conditions. There's some people that are teenagers, right? There are some people who are about to go to college, right? And so we have to acknowledge that and there's other people with stigmatized racial ethnic identities or ability status or whatever it might be, right? That we also might make assumptions about whether we think a pregnancy would be good for them, right? Or whether a unplanned pregnancy would be good for them. And those are the people that are often targeted the most by directive counseling models, right? So it's really important to acknowledge that this narrative of the reality, not the narrative, the reality of stratified reproduction, the fact that we make judgments about who is fit to parent and what parent, and sometimes it's, again, benevolent that we think that we are helping people. I've heard people see, like, if I literally heard someone say, like, if she just have an IUD, then I think maybe she can be an astronaut, right? It's like yeah. I don't know why. I know. And I'm like, this is not that's not true, right? And B, that's not your job, right? Your job is to provide this patient with care that meets their needs as they themselves define it in an equitable way that honors their reproductive autonomy, right? That is our role. So having this narrative about what contraception can do for someone interferes with our ability to be there for them in their humanity. So it's not the silver bullet for teens or anyone else. So I'll just go through this quickly. So acting on judgments about who should prevent pregnancy interferes with reproductive autonomy. Okay, I said that. So our goal is to establish a trusting relationship with healthcare providers. We know that when patients have bad experiences, that they carry them with them for their lifetime, and it actually interferes with their ability to get reproductive healthcare that they need later. So when we might think like, oh, we're being benevolent, like there's a paper that my colleague wrote saying, I wouldn't be this firm if I didn't care about counseling teens, right? What that's actually doing is you're interfering with the patient's ability to get their needs met in the future. Yeah, that's good. I always like it when I get to my bullet point ahead of time. Okay, so putting this all together, contraceptive choice is preference sensitive and personal, right? We are not counseling people with the agenda of preventing unintended pregnancy, which is what the directive counseling model is pinned on. The idea that an unintended pregnancy is a universally bad outcome that we should be counseling against, and we have the agenda about that. In fact, it is a preference-sensitive decision with patients having diverse preferences for whether or not effectiveness is most important versus control is most important. And when we provide directive counseling, we are not meeting people where they're at and not providing person-centered care, and we're also not prioritizing reproductive autonomy. And we also know that pressure to use specific methods can be counterproductive. It interferes with people's access to care in the longer term, and it can actually lead to method discontinuation and lower satisfaction with their method. This is some research that we did. So then is the right approach to counseling not contributing to the decision at all? So you already said that you like the idea of just giving patients all the information and letting them decide. So this is what's called the informed choice model of counseling, and it's providing only objective information and not participating in the method treatment selection itself. I call this the Cheesecake Factory version of is Cheesecake Factory out here? Yeah, okay. Like, maybe I shouldn't have them in San Francisco. So, I mean, but isn't the menu overwhelming? Like, okay, thank you. See, it's a universal shared experience. And then the other model of what's called consumerist counseling, which is like, letting the patient lead, is this foreclosed model, which the patient comes in, you say, what do you want? They say pills, and you're like, there's the pills, right? For example, those are the two versions of like deferring to the patient. So my argument is that these are not ideally patient-centered models. So I'm going to, like I said, I'm going to problematize that answer a little bit. So informed choice doesn't help patients in understanding their preferences, how their preferences relate to method characteristics, right? Like when you go to a restaurant, you sometimes say, well, is this one any good? Like, what do you think of this? Like, is the fish fresh? I'm vegetarian, but whatever. And you tailor the information to the patient's needs, right? So that is not happening in informed choice, right? And the foreclosed model, you also don't know if the patient even knows what they want. I always say with the foreclosed model, often people come in thinking that they're supposed to know, because the first question we often asked, I don't ask this, is what method do you want? Or what have you used? And it's like a way to short track the conversation so you can actually get done with see your next patient, right? Again, we are all harmed by the system. But patient, you don't know. Does patient even know that there's like patch rings, IUDs? You don't know, right? If you do a foreclosed model. So I would argue that both of these are not ideally patient-centered. So this is, again, we'll go into far more depth about this in a future session. But if you think about these as two poles, where there's the consumerist deferring to patients completely and not participating. We always want to defer to patients, but not participating. And then there's directive counseling, right? They both have these kind of tenets. Consumers counseling is all about patient autonomy, right? We are not impinging on that autonomy. And the pushback against directive counseling has led to a lot of people being like, okay, that's fine. I just like, here's information, take it away. Directive counseling obviously is about talking to patients about effectiveness primarily, but it's still important that we talk to patient about effectiveness, right? That we do make sure patients are considering effectiveness alongside other considerations in making a method choice. Am I talking too fast, Rachel? Am I okay? Okay. I'm a fast talker, but people tell me they can follow. Are you guys following? Okay. All right. So really what we want to do is find the middle ground and do a quality decision based on patient preferences, a quality supported decision. And this is the concept of shared decision-making, which I'm sure many of you heard, right? It's really important that shared decision-making is not the same thing as patient-centered care, right? Because patient-centered care can be motivational interviewing when you have an agenda. Shared decision-making is when you don't have an agenda and you're really just about supporting patients to consider things, to consider the full range of options with respect to their needs, values, and preferences. And so shared decision-making is a collaborative process that allows patients and the providers to make healthcare decisions, taking into account the best scientific evidence, as well as the patient's needs, values, and preferences. And the process provides patients with the support they need to make the best individualized care decisions. Rachel and I were talking about this last night. Super important that shared decision-making is not thought of as that you actually like have to have a kumbaya moment and the provider gets to have like an equal say in the decision, right? It's that it's a supported and collaborative process, but it's ultimately up to the patient, right? The final decision. So we've done research that has found that people want this in contraceptive counseling, right? And that, I mean, I came to shared decision-making as a family doc in other contexts. And then I did my family planning fellowship and I was like, why is no one talking about shared decision-making in this context? So I was like, let's ask people. And this is what we found. And we've also found quantitatively that in survey data that people who have report that they had a shared decision-making actually have higher satisfaction with the decision-making process. What I'll go into in more depth in the next talk in the other session is that it might not be the best for everyone. Some people want informed choice. Some people want foreclosed counseling, but this provides a starting point to make sure that you meet people where they're at. So this is from one of our qualitative studies where a patient said, I just think providers should be very informative and non-biased, not try to persuade them to go one way or the other, but maybe find out a little bit about them and maybe suggest what might work best for them based on those things, but ultimately leave the decision up to the patient. So that is really shared decision-making. So this idea of shared decision-making is consistent with Sister Song and the National Women's Health Network statement on LARCs that came out in 2017, where they were pushing back against the directive counseling model and said that people need to be supported in identifying the method that best meets their needs. It is also now and supported, I underlined that, I forgot I did that. It is also consistent with what now is the ACOG guidance. The old ACOG guidance, well, I don't know, ACOG has multiple guidances, but their original guidance was first line tiered effectiveness counseling. In 2022, they came out with this statement instead, and they talked about the need to consider a patient-centered reproductive justice framework and use of a shared decision-making model to help patients achieve their reproductive goals. And they talk specifically about the need to remember that there are social and historical contexts that can interfere with patients' reproductive autonomy. Okay, where am I at, Rachel? I'm way over, huh? Okay, okay. So that's the basic model that we want you to take away from this, is that a health equity-minded, reproductive justice informed, person-centered, and reproductive autonomy-focused approach to contraceptive counseling is shared decision-making. Being very clear that you have to prioritize patients' needs, values, and preferences and let them make the ultimate decision. I'm now going to say a little bit about how this relates to the reality of inequities and racial bias in contraceptive care that Rachel talked about earlier. So we have to be aware of the social and historical context when we were providing care to patients, and particularly patients from minoritized communities, and be very explicitly and consciously aware of the potential to impinge on reproductive autonomy, or even to have the appearance of impinging on reproductive autonomy. So this again is that as from the same study, and you're not gonna be able to read this either, but from the same study that I showed earlier, where we asked people about the needs, values, and preferences for contraceptive methods. And the second analysis that I participated in looked at it by race ethnicity to see, are there differences in preferences by race ethnicity? And what we found is that there were over these a couple of things, but one is I can get it without seeing a doctor or going to a clinic. Black and Latina patients were more likely to say that that was important to them. I have control over when and whether to use the method. Same. I can stop using the birth control method at any time, right? So there is a reality of reproductive oppression that influences method preferences and how people are thinking about their options. And importantly, those track onto method characteristics that are associated with IUDs and implants, right? So what this tells us is that, we don't want to assume anything based on a patient's race ethnicity in terms of what their preferences are, right? But what this tells us is that directive counseling is problematic at baseline. And it's particularly problematic because it's going to meet the needs of populations who have already experienced and continue to experience reproductive oppression even less well than it's going to serve patients, white patients. So it's more discordant with their preferences to provide directive counseling towards IUDs and implants, and therefore it's going to worsen their experience of care even more. So we also know that in addition to all the history that and data that Rachel presented about disparate treatment by race ethnicity in contraceptive care and reproductive health care in general, we also know that this shows up in counseling about specific methods as well, right? So we know that from a study that was done in actually 1988, that providers are more likely to agree to sterilize women of color and poor women. This was based on a vignette-based study where they asked people, would you agree to sterilize this person? And then when I was doing my family planning fellowship, like I said, I was really interested in knowing, was this the case with respect to LARC methods as well, right? I was like I said, coming of age in this period where it was going to save the world. And I was curious that are there disparate recommendations by race ethnicity in recommendations for LARC? So what I actually did was created standardized patient videos varying by race ethnicity, and in a randomized fashion had providers, mostly MDs, at national conferences of ACOG, the American Academy of Family Physicians, just them, which is why I got mostly MDs. And it showed them in a randomized fashion and asked them what methods they would recommend to that patient. And what I found was that, and this is like level 1 evidence, right? Tier 1 evidence, it's randomized design, all of that. What I found was that providers were significantly more likely to recommend IUD to Black and Latina patients shown in the videos than they were to white patients, right? And what this tells us is that directive counseling is problematic. We already talked about that. It's more discordant with the preferences of Black and Latina patients, and providers are disproportionately enacting directive counseling and recommending these methods that are discrepant with preferences to Black and Latina patients. So overall, this just tells us that we are worsening care experiences, particularly for patients whose care experiences are already particularly problematic. So put that together, we need to be really aware of this, of the historical social context, the documented disparities in counseling, and how this has and continues to result in earned mistrust of contraceptive services. A lot of time when we talked about mistrust, we're like, oh yeah, patients just don't trust us because, but they just don't, because they don't understand. It's earned mistrust. We have to own it as part of our healthcare system, right? And directive counseling can particularly contribute to negative experiences for patients of color. And for all patients, we have to focus on individual preferences, and we have to be really very clear and aware, again, using a universal precautions trauma-informed approach, that that there can be potential for patients to come in with bad experiences and ways that they interpret the way that we talk to them that can reinforce and reproduce negative care experiences. So you can't just say, like, someone tells you that they want a highly effective method and you're like, okay, well then you should use an IUD or implant. You have to say, okay, I get into this in more depth, but okay, from what I'm hearing from you, this is the most important thing to you. Is that right? If so, these are the methods. This is the difference by efficacy in the methods. And would you want to talk about these? Because I'm hearing what you're telling me. Those two things come across very differently. And so shared decision-making provides an explicit framework for doing this without swinging too far to the other side. Great. Okay, so that's counseling. I think I took too long. Oh, I'm good? Okay. Oh my God. Okay. Any questions, thoughts, reactions people have?
were talking about, like Black and Latinx patients preferring the methods that do not go with do not require providers. I mean, besides, probably them wanting some maybe convenience, I also thought maybe it could be their interactions with providers are so negative that they don't want
Exactly.
the doctor or a nurse practitioner when it comes to talking about birth control.
Yes, absolutely. And so it can be kind of lived historical community knowledge, or it can be their own personal experiences. And we also know, I mean, LARC removals, we'll get into that in the actual session, but like people experience barriers to getting their life removed when they want it. And that's something that people may have experienced themselves or may have known people who've had. So absolutely. Any other thoughts? One, I'd written this down. I forgot to say it during the slide. There's a quote by a woman named Kristen Luker who wrote the book, Politics of Teen Pregnancy Prevention. Is that what it's called? Yeah. And it's a quote that I like carry with me because I think it's really powerful and it's controversial, but I think it's important to bring to the room. She says the teen pregnancy prevention is race and class eugenics couched in the veneer of earnest concern. So I think that this goes to what Rachel was saying earlier about it's about what fertility is desired and what fertility we think is optimal and how we enact that. And unintended pregnancy is one framework we use to kind of judge it and kind of sanitize whose fertility we talk about. It actually comes from the unintended pregnancy framework. I didn't say this comes from eugenics and comes from white supremacy explicitly in the 1930s. That's where the planning framework came from, was switching from a voluntary motherhood framework to one of pregnancy planning because of white women weren't having enough babies, right? So it was sanitizing eugenics. And I would say that teen pregnancy prevention is similarly racialized, and that's where that quote comes from. Is there anything you would say about that, Rachel?
No, I think it's really important that, and we were talking about this last night, but in the sexual and reproductive health space, we don't rely as heavily on evidence as we do for other types of medical care. Like there is an exceptionalism to sexual and reproductive health that if something kind of tingles our norms, we kind of adopt it and accept it without clear evidence. Like almost every paper from like 2007 to like maybe the last 5 years started with 50% of unintended pregnancies in the United States, or 50% of pregnancies in the United States are unintended. And it has all of these negative outcomes without there being clear evidence that exists. The same with the teen pregnancy thing. We inherently believe that adolescents should not have pregnancies, and that we are responsible for ensuring that they don't do that. And again, there's not clear evidence. And so that is just another way that it reinforces this idea that certain people should be kept from having children and having a certain number of children, and other people should be assisted in their desires. But it all goes back to forms of control.
Thank you. Any reactions? Okay, well, now we're going to talk about the other aspects of the clinic visit, right? So that's kind of the background we want everyone to have, right? But because it's not just about whoever the counselor, who does the counseling actually at Ybor? Is it a health educator, a counselor, a clinician, usually? Clinician, okay. Okay, so it can vary in different places. Obviously, sometimes there's like dyadic counseling that the RN does it, and then the clinician, the NP or MD takes over. But regardless, even if you're the front desk person, right, you are interacting with patients about their method choices. You can have and you have an influence as well over their overall experience of care. So I want to talk a little bit about that. So this is kind of the way I'm thinking about that. You know, there might be slight variations in this in different contexts or in your context, but this is kind of a patient journey through a clinic experience is making an appointment in some way, shape, or form, checking in, being seen by the nursing staff, health educator, including medical assistants in that, seen by the counselor and or clinician, and then checking out, right? So counseling is really kind of focused on this part of it, but it's all relevant. So I want to talk about how that's all relevant. everyone contributes to person-centered care. So it's important both in terms of how each individual person that makes contact with the patient, even if it's eye contact, right? It can influence the patient experience, but it's also about how we work together as a team, right? And so that's, and that contributes to patient's experience. So I think that's really important. Okay, so I just want to ask you all to, we're going to go through a case and kind of get some thinking about this, but what do you think are some opportunities for person-centered care at each step in this?
They put in a computer that I needed STD testing and it like totally derailed the whole thing.
Thank you for that great example. Yeah, so if you get somebody who then decides that you need a service that you don't actually want, and then it's like you're in a pathway. Yeah,